Welcome to this regional discussion group for South Asia. This is the second of our series of three over these 3 months. Welcome to all of you who are joining. As people settle in, please feel free to say hello in the chat and who you are and where you're from. It's wonderful to see so many people joining. As you know, many of you have joined these meetings before, so it's wonderful that to see you again. I am the Chief Executive of the International CML Foundation, and as you settle in, I'll just give you a brief introduction of our programs and aims. So the International CML Foundation was formed by a group of dedicated hematologists with the view to improve outcomes for people with CML all around the world. We do this really in two key ways at the moment: by raising the bar of CML management through our educational programs, which you can see. We've had over 200 clinical preceptors. And again, many of you in this meeting have been part of one of these preceptorships. We hold webinars, these ICMLF conversations. We have the highlights of EHA coming up at the end of June, so please watch this space for that. We also have Papers of the Month, which Professor Hughes highlights every month. And really the aim is to share the expertise that is part of the International CML Foundation. The other part of the foundation for you to be aware of is just how the global research that we're undertaking. So we have the Global Alliance looking at clonal hierarchy in CML, and we have best practice for treatment-free remission, the Alliance looking at that. CML and hepatitis B, a survey of practice, and our pediatric treatment in low middle income countries, which began as a survey, and we're looking to extend that out to how we can further help pediatric treatment of CML in lower middle income countries. But these regional discussions really are an excellent way of connecting with you in South Asia. And I'm now going to hand over to my colleague Arlene, who will take this meeting forward. So thank you for joining us, and we look forward to the discussion.
Thanks so much, Nicola, and hello, and what a great pleasure to see so many familiar names and faces in the audience, and some new ones too, so great to see you here. Okay, so our first topic for discussion today is the realities of long-term treatment, managing the chronic effects of TKIs, chronic complications, and other challenges. And it's a great pleasure to welcome our international expert for this topic, Professor Mike Mauro from the USA. Mike is the leader of the Myeloproliferative Neoplasms Program. He's a member of the Memorial Sloan Kettering Cancer Center and professor at Weill Cornell Medicine. Welcome, Mike. You are such a giant in the field, and a great privilege to have you here today. Welcome.
Thank you. I'm actually not that tall. I'm not a giant at all. I'm only about 5'5.5".
Our regional expert for this topic is Professor Mehreen Ali Khan from the Armed Forces Bone Marrow Transplant Center in Rawalpindi, Pakistan. I first got to know Mehreen when she did a preceptorship at MD Anderson in Texas in the USA with Professor Jorge Cortez, and she's been a friend of the foundation ever since. A leading woman in the field. I hope it's the first of many opportunities that we have to learn from you, Mehreen. Welcome.
Thank you very much, Arlene. It's a real honor for me to be presenting cases in ICMLF regional discussions. It's a very nice journey with the International CML Foundation since 2017 when I did my preceptorship program in MD Anderson. And I'm really proud that an organization is looking after this huge burden of chronic myeloid leukemia. Thank you very much. And my many colleagues and students are here in the meeting today.
That's wonderful. That's great. So Mehreen, if you could please share your slides with us. And as you're getting your slides up, I'll let the audience know how we plan to run this session. So Mehreen has brought two cases to share that illustrate some of the key issues faced with long-term CML treatment, which in the first instance, we'll have Mike address questions and issues, but then we will open up to you, the audience, and the other experts for discussion. And we are lucky today that the junior consultants who have actively managed these cases under Mehreen's supervision, that is Dr. Mariam Khan and Dr. Hamad Javed, are also present and keen to be involved in discussing these issues. So welcome,
Is
Mariam
mic on?
and Hamad. Okay, looks like we are ready to go. Just before I stop speaking, I'll properly introduce the experts for the next topic when we get to it. But for now, can I just acknowledge, please, that Professor Sadashivudu Gundetti and Professor Naeem Chowdhury are in the audience already. And we welcome, of course, any contribution that they would like to make to this discussion. Okay, Mehreen, you look like you're ready to go.
Yeah. Thank you very much, Arlene, once again. I hope my voice is audible to everyone. And Professor Mauro, thank you very much. Professor Naeem Chowdhury, thank you very much. So I would like to share my first case. It's a case of TKI-resistant chronic myeloid leukemia, post-allogenic bone marrow transplant, and TKI-induced complications. So this case was managed very well by our team, but let's see what the experts say. And in the team, my junior consultant, very brilliant, Dr. Hamad Javed and Dr. Mariam Khan were with me in both these cases. So the sequence of events in this case is diagnosis and initial treatment. Patient had pregnancy. She's a female patient. She relapsed. Then allogenic bone marrow transplant was planned. Post-BMT course was fine till 1 year, and then she had molecular relapse. We gave her donor lymphocyte infusions, DLI, 3 doses, and then she tried every TKI under the sky. I'll be telling in a few minutes. And finally, disease transformation. So the story starts 10 years ago in August 2014. The 31-year-old lady who was recently married at that point in time did not have any comorbids. Initial presentation was in August 14. She was pale and having weakness. Full blood counts revealed 96,000 WBC count. Hemoglobin was 9.4 gram per deciliter, and platelets were 440 into 10 raised to 9 per liter. Peripheral blood film revealed leukocytosis, neutrophilia, basophilia, and bimodal peak, very typical of CML. And bone marrow examination had myeloid hyperplasia with dwarf megakaryocytes, very typical of chronic myeloid leukemia. We did the tree-fine as well. In cytogenetics, Philadelphia chromosome was visible. That was abnormal, shortened chromosome number 22 after 922 translocation. And PCR was positive for BCR Abelson 1 P210. So diagnosis was simple, that is chronic myeloid leukemia in chronic phase. Initially, she had high ELTS score, and she was started on second line, that is Nilotinib, 600 milligram per day. She achieved molecular remission in 6 months. So 2015 to 2017, she had pregnancy in September 2015. She told us in the clinic, and we immediately stopped Nilotinib after conception. She was on PEG interferon from December 2015 to May 2016. Postpartum, when we checked the status, she had hematological as well as molecular relapse despite being on interferon. Her spleen was 3 centimeters below the costal margin, and PCR was positive for BCR Abelson 1, P210. IS was 46%. So we restarted Nilotinib and continued for next 1 year, but she had a hematological response, but no molecular response. No further TKI was available at that point in time in our country, that is 2015 to 2017. She was referred for bone marrow transplant to our center. She had 5 siblings, 2 sisters and 3 brothers, and one of the sisters were fully HLA matched. She was married and having 1 daughter. So we planned conditioning with myeloablative conditioning, BU-PSI, BU 12.8 IV, and PSI 120 with ATG10. GVHD prophylaxis was methotrexate and cyclosporin, and the date of transplant was 8th of October 2018. So we use bone marrow harvest as stem cells because whenever we use peripheral blood stem cells for CML especially, it's lots of GVHD. So it's a institutional policy to use bone marrow harvest stem cells. The dose was CD34 was 5.8 into 10 raised to 6 per kg of the body weight of the recipient, and TNC, that is total nucleated cells, were 4.3 into 10 raised to 8 per kg. She achieved neutrophil engraftment on day 16, which was very good. Normal, our average is day 13 to day 18. And she was discharged on day 18. and platelet engraftment was achieved afterwards on daycare basis. The peri-transplant issues were mucositis grade 2. We initially planned 3 doses of methotrexate post-transplant, but due to mucositis, we could give only 2 doses, 10 milligram per meter square on day +1 and 8 milligram per meter square on day +3. She had a bit of gut toxicity as well, and she was managed accordingly. Post-allogenic bone marrow transplant assessment at day +30, we normally do assessment at the day +30, day +60, day +90, day +180, and then 360. So at day +30, bone marrow examination revealed successful engraftment. Short tandem repeats for donor chimerism were more than 95%, and PCR for BCR-ABL was negative. So she was in molecular remission with successful engraftment. As per institutional policy, post-allogenic bone marrow transplant follow-up continued. She was followed up initially twice a week, then weekly, then fortnightly, and then monthly. She was intolerant to cyclosporin, and we tried tacrolimus as well, but she had nephrotoxicity. So immunosuppressive therapy was in the form of mycophenolate mofetil, that is CellCept. In December 2018, before day 100 of transplant, she had acute graft versus host disease, liver, gut, and she was managed with steroids, and we started ibrutinib for her. She had CMV reactivation, and oral valganciclovir in the dose of 900 twice a day was given, and it was treated in 3 weeks. She also had BK virus-induced hemorrhagic cystitis in January 2019, that is 3 months after transplant, around 100 days, and she was managed conservatively. Then she had chronic GVHD as well, oral cavity and eyes in February 19, and chronic GVHD lung as well in April 2019. And she was managed with steroids, CellCept, and ibrutinib. So a year post-transplant, she was fine. All the milestones were achieved. Molecular remission was documented. But in November 2019, that is almost a year post-transplant, that is 13 months post-transplant, her PCR, BCR-ABL was positive, IS was 0.07%. She initially, nilotinib was not started because this was a chronic phase and she did not require nilotinib. But at this point in time, we started TKI, Tasigna 600 milligram OD, and we planned donor lymphocyte infusion. First dose was given, that is 1 × 10⁻⁶ per kg, and PCR post first dose was 0.0046%. Then second dose after 12 weeks, that is 5 × 10⁻⁶ per kg in February 2020, and third dose was given in April 2020. But despite these 3 doses of donor lymphocyte infusion, molecular remission could not be achieved. PCR was persistently positive. So the dose of nilotinib was increased to 800 milligram once daily. So the further management includes donor lymphocyte infusion and TKI refractory disease post Allo-BMT. So we started her on asciminib in August 2020. At this point in time, we had the access to asciminib. Dose was escalated from 40 milligram per day to 200 milligram BD till January 22. So August to January, we kept on increasing the dose of asciminib. She remained well. Molecular remission could not be achieved. Blood count remained stable and PCR was positive. So in August 2023, while she was on asciminib, she presented with severe abdominal pain, and here that TKI-related complications start. She had portal vein thrombosis, severe abdominal pain on 2nd of August 2023. She came to us, we examined her, we ordered a contrast-enhanced CT scan of the abdomen. It was extensive portal vein thrombosis involving inferior mesenteric vein, superior mesenteric vein, and there was mild ascites as well. So initial treatment was with low molecular weight heparin, and opioid had to be given for abdominal pain. And after this, on 11th of August, that is just 9 days afterward, she had intracerebral hemorrhage. So it was a devastating complication. She had severe headache, CT brain was ordered, and she had subdural hemorrhage and parenchymal bleed. Obviously, low molecular weight heparin was stopped, and intracranial hemorrhage was managed with dexamethasone, mannitol, and levetiracetam. So she had chronic portal vein thrombosis till 11 September 2023. Abdominal pain was persistent off and on. She was admitted with us. Hematemesis, CECT showed chronic PV thrombosis with cavernous transformation and portal hypertension. Low molecular weight heparin was restarted at 50% dose because of low platelets. Later on, she was switched to rivaroxaban 10 milligram OD on 19th of September 2023. Parenteral analgesics had to be given for abdominal pain. She would have severe abdominal pain. She was anxious, of course, low mood, depression. And then at this point, we started her on ponatinib 15 milligram per day, which was escalated later to 30 milligram. TKD mutation was not available till then. So in March 2024, she came to us with an episode of hematemesis. She was admitted in the hospital for resuscitation and further evaluation. Blood counts showed revealed raised WBC. Initially, it was 56,000, then 70,000, and then 90,000. Peripheral blood film examination revealed blast, and bone marrow examination was done to confirm the blast phase of chronic myeloid leukemia. At this point in time, this anxious and depressed patient refused to go for further flow cytometry, further classification of this transformed disease, whether it is AML, MPAL, or lymphoid leukemia. So to summarize, it's a complicated case of chronic myeloid leukemia, TKI resistance, initially treated with allogenic bone marrow transplant. She had bone marrow transplant and post-bone marrow transplant relapse of the disease in 13 months. We planned DLI, donor lymphocyte infusion, thrice. She was given DLI, but there was no response. And then she was shifted to third and fourth generation TKI as well. She was having TKI-related thrombosis, being on asciminib, and now the disease has transformed to acute leukemia. So this is the story of 10 years in chronic myeloid leukemia in a young female. So Professor Mauro is here, Professor Naeem Chaudhry is here, and the audience. What could have been done better? One, and any suggestions for further management, especially when this patient is obviously tired of this chronic disease and doesn't want to have further management.
Mike, over to you in the first instance.
So where shall I begin? Wow, that is a very complicated case. We had some questions come in the discussions. I think everyone's been thinking hard on this. Maybe I could just ask you a few pointed questions. So mutation, you just mentioned just a moment ago, mutation testing wasn't available readily. Were there any points where mutation testing were done? A lot of folks were wondering me as well about mutation analysis, for example, with nilotinib resistance. And I think the second point people thought might be helpful would be around the time of asciminib, perhaps as a justification for the higher dose. Of course, at the end of the journey, unfortunately, the mutation testing might also be helpful to understand what happened. But any comments on that?
So at that point in time, the TKD mutations were not available. Now, our largest institute has established it, but we're in the process of optimizing it. And we could do T315I, which is negative. So we were just trying to have more and more second line and third line and fourth line when asciminib was available. Unfortunately, she had a good quality of life in these 10 years, but molecular response was never achieved. So one is if it is blast transformation, we do flow. If it is AML, we treat it like AML and go for second transplant to rescue. Or if it is ALL, we treat like with the UKLL protocol and go to the second transplant. But the patient at this point in time is tired of the disease and not having the performance status to get extensive chemotherapy. So this is the story, and she is now palliation with what she has opted for.
A question actually came through about this, which always is a question when you have relapse post-transplant or you have disease post-transplant. The unusual situation, could this be a treatment-related secondary leukemia? You probably don't have any ability to ascertain that because the patient didn't want to undergo further testing.
For 1 year, the donor chimerism was fine, and she was fine. But when she relapsed, the molecular relapse was there. But obviously, donor-associated leukemia could not be ruled out, obviously.
Yeah. So I'm just going to walk through from the beginning. I would say I think we all face a dilemma of honoring the wishes of a woman wanting to start a family. And, I think we all recognize that that wasn't enough treatment duration for her to have a stable course through pregnancy, although I commend your use of interferon to do the same thing. And also promptly discontinuing the TKI, although I think the aggregate experience with TKIs in pregnancy is in Nilotinib may be one of the medications that can be introduced probably later in pregnancy with some trepidation, but probably the least likely TKI, imatinib and nilotinib to cause harm to the fetus. So, but trouble started then. I think when the postpartum nilotinib didn't render her back into remission. So, that's the difficult point. I think that there's literature to support that women treated not of long enough duration have a tendency to progress or transform, even if they're have such an interruption. And then we talked about maybe having mutation analysis then, but we didn't have access to it. And also you didn't have other TKIs. So I think the allografting made sense. And I was thinking about, sort of the history of low-level MRD in the post-transplant setting as you're, describing her relapse with that must have been a challenging point. And I'll maybe open up to you and the colleagues who help manage the patient with low-level MRD, even up to 12 months post-transplant in a patient that actually had graft versus host disease to go ahead and to sort of boldly give donor lymphocyte infusions in the face of GVH with low-level disease. I think we struggle with, do we give TKI? Do we give DLI? Do we do both? And also this question about what's the kinetics of disappearance of MRD after transplant. But this was disappearance and then return. It wasn't that she was MRD positive the whole time. But maybe I'll stop there. And if anyone has any historical comments to make, the team and yourself included.
So I have a question, if Professor Mauro or Professor Chaudhary or any of the audience can answer. So how can we prevent thrombosis induced by TKI? Is there any, how can we prevent thrombosis when we don't have any option? Obviously, we have to give TKI. So in this case, we give TKI and DLI both. So the moment we see molecular relapse, the best option is to restart TKI along with DLI. We did that. But normally patients, after first dose of DLI, and especially in CML, they achieve molecular remission as well as some of GVHD as well. So in this case, we couldn't achieve that.
Yeah. I think your question was about...
Hemant Malhotra has his hand up.
Oh, yes.
And there are so many questions coming through in the chat. I'm struggling to keep up with them. A lot of them are very similar. I wonder if we could invite Hemant to comment. Mike, could you have a flick through the chat and make sure, a lot of them are very similar, but if we've missed anything, you can bring that back. Hemant, a comment from you?
Good evening, good morning, wherever you are in the world. And hi, Mike, good to see you.
Same here.
So I have a question, Mike, considering the, exorbitant cost of the STAMP inhibitors all over the world, if you have a patient who has the T315I mutation or who is 4 TKIs resistant and still in the chronic phase, would you think that a transplant might be a better option than the extremely expensive, STAMP inhibitors?
I think that's a very robust discussion that's happening right now. I think we moved away from philosophically transplanting patients with stable chronic phase CML in my country. But I think the cost of long-term use of novel agents, especially right after they're approved, really philosophically is put up against either a generic drug, which would be lower cost for simpler resistance, not T315I, or allografting. So I think the problem is, Ahmed, is that that patient probably should have had transplant introduced when they had their first or second instance of resistant disease. So it should have been an active discussion all along, not a, we're going to just keep using TKIs until we, have no more TKIs. So it becomes a risk-benefit analysis the whole time. And if I have a patient who's not achieving reasonable levels of remission, cytogenetic remission or major molecular remission, that's the discussion. Even in my hands in the U.S., it's not often opted for. And of course, I have the luxury and many trials as well. So I try to use TKIs, but I really don't want to see patients lose the opportunity to have a curative treatment for CML, even if it can be complicated with, such as this case was in the allograft, and when the patient was allografted. So you raise a great point.
Can I add something? So situation is very similar in my part of the world. So TKI are much more expensive than allografting. So when we started transplanting in 2001, we used to transplant each and every one in chronic phase, especially the younger ones, because they didn't have the finances to support themselves throughout the rest of the 40, 50 years, because the incidence of CML here in this part of the world is in second and third decade, as contrast to the rest of the world. So initially we used to transplant chronic phase as well, but with the Novartis Oncology and Access program, it was made available to many patients. So then we started picking up the patients who were either accelerated phase or blast crisis or TKI resistance. So these are the three indications for CML in transplant at our institute now.
Yeah. I'll just say one other counterpoint in that I'm a very strong proponent of treatment-free remission and try to work and research in second treatment-free remission. So you can think about it slightly differently. If you're able to use a novel TKI and reverse the, the clinical phenotype to a very sensitive disease that's in, MRD only or MRD negative state, like basically a patient who's now TFR eligible. We haven't asked that question yet about, can a patient be put into a TFR scenario after multiple lines of, other TKIs in the chronic phase? That would change the equation, because then you'd have short-term use of a novel agent. I'm not confident that that's going to be the answer, but I think that we should at least explore it, or a second treatment-free remission, because a short-term TKI at great cost might actually, if the patient has a complicated course, may wind up being less to the healthcare system because of the chronic GVH and the care that's needed for that host of complications. Dr. Ali Khan, I want to ask you about the thrombosis. That was a surprising toxicity to me. I was not expecting portal hypertension and venous thrombosis in the abdomen as a complication of asciminib. I think I've looked pretty carefully at the asciminib toxicity data, skeptically, because I'm leery of vascular toxicity, and I don't. Do you think there was any other factors there? I would suspect there might be with chronic GVH and other things going on, rather than the asciminib.
Actually, she was given all three types of TKI before that. So she was constantly for these 10 years on either nilotinib or asciminib, and then shifted to ponatinib. So we think this was TKI induced, but this was quite an extensive thrombosis, and then it became chronic, and there was cavernous formation as well. And then we started her on low molecular weight heparin, and then she had intracranial bleed, and we had to stop it. So this is how it is. We frequently encounter with TKI-induced thrombosis. It's not very uncommon here. So I don't know what's your experience. Yeah.
Hypertension is well noted also with asciminib, especially at a higher dose. My one question was, in this case, Mehreen, was when there was no GVHD with the DLI, the third dose, did you not decide to go up on the dose of DLI if your access to TKIs was not there?
So we tried thrice. So escalating doses of DLI after 12 weeks and second one after 8 weeks. But she did not respond, and we were just afraid of more GVHD, and then we didn't try anymore. So initially she had GVHD, which we managed with steroids and ibrutinib. So this is how it is.
There seems to be a lot of questions about the mutation. There seems to be a lot of questions about the mutation. Obviously, it was not available.
I know.
But it looks like the first time there probably was not the T315I, because the patient did respond to nilotinib and then asciminib. But at the later stage, when patient was not responding to even the higher dose of 200 milligram, there is a possibility that there could have been a T315I mutation.
Yeah, there must be additional mutations in this case, and sorry, we couldn't get the results at that point in time. Now we are able to do the TKI mutations in our country. And another thing is about TFR. So TFR is also quite expensive for patients to get BCR-ABL done 3 monthly. It is very, very expensive. So very few can opt for it. And whoever opts for it, yes, we provide TFR trial. And 50% of them are off TKI.
No, I understand that. I think these are great points. I think I acknowledge the pre-treatment with other TKIs might have risen, driven up the thrombosis risk, and the point made by Professor Chowdhury about the mutation evolution. I think we all want to have a crystal ball going backwards, looking at the mutation evolution this patient might have been evolving through time. There's some interesting data that some mutations that may be, you'd expect them to be resistant to the active site inhibitors that affect the kinase hyperactivation or activation, or the SH3 domain that might be involved in asciminib resistance, not just these myristoyl pocket mutations. So sometimes it's complicated. And then maybe one last question on this case that we haven't answered is, what is someone asked the provocative question, what are the minimum tests to do to regularly predict nilotinib-induced thrombosis? So that is the, what kind of vascular monitoring does a nilotinib patient need? And I would say, I don't know if we've been able to answer that question. I've tried to tackle that in a study here for all comers and frontline, what vascular studies are predictive. I would say follow the patient with standard cardiovascular tests as best you can, and try to pick up things like, metabolic disease change, diabetes, hyperlipidemia, managed hypertension, which can happen on any TKI. I'm not sure if we have any predictor, unfortunately, but this was a great case, and I think we probably have to keep moving because we probably have other great.
Yes. With one eye in a time, we need to keep moving. So, Mehreen, thank you so much. We knew that case was just going to be so rich. Please get your slides up for this second case. There are so many comments and questions coming through here, but we will move on to the second case and try and pick up some of these questions at the end. Let's keep going on this one, and of course, experts, please, if you could keep an eye on that chat as well, and pick them up.
Okay, so thank you very much, Professor Mauro, Professor Malhotra, Professor Naim Chaudhary, for your input, and thank you very much, Eileen. So the second case, so it's a 38-year-old male, a resident of Azad, Jammu Kashmir in Pakistan. He's lawyer by profession, married and having 2 children, and he presented in August 2022 with fever, weight loss, and bilateral visual impairment for the last 1 month. This case was very nicely managed by my younger colleague, Dr. Mariam Khan. She's also here. So bone marrow examination showed acute blastic transformation. So 15% of the blasts were positive for lymphoid markers, and 10% of the blasts were in the gated window. 10% were positive for myeloid markers, that is CD33, 117, and MPO. So it was actually mixed phenotypic acute leukemia, and this was the first presentation of this gentleman. PCR for BCR-ABL was positive, P210. Cytogenetics showed normal male karyotype with Philadelphia chromosome. TKI mutation, again, not available at baseline. Our apologies. So he received UKLL regimen 2014 induction with nilotinib. His chemotherapy protocol had to be withheld on day 6 of induction due to hyperbilirubinemia, and it was indirect hyperbilirubinemia, 100 to 120 micromole per liter. So indirect hyperbilirubinemia persisted, and nilotinib was withheld, and then restarted. Chemotherapy was restarted, and nilotinib was reintroduced at a lower dose. Initially, we gave him 600 milligram per day, and when we started with 100 milligram per day, and then gradually escalated. And re-challenge of the nilotinib also led to rise in the bilirubin again. Patient remained asymptomatic. There was no symptom. So TKI during induction remained interrupted due to persistent indirect hyperbilirubinemia. Maximum was 120 micromole, and TKI was later changed from nilotinib to dasatinib. So end of induction, UKLL 2014 with TKI, bone marrow was in CR, and MRD was negative. PCR for BCR Abelson 1 showed major molecular response. At this point in time, obviously, search for donor. He had no HLA matched donor, and he had one haplo matched brother, but donor-specific antigen were very high with high MFIs. So UKLL 2014 induction phase 2, CNS intensification, consolidation 1, 2, 3, and 4, and maintenance cycles were continued as per protocol. He continued to have 3-monthly BCR Abelson 1 monitoring, and he was in remission, developing rise in transcript up to 1% by flow MRD, which when it became positive while on being on dasatinib, he was shifted to ponatinib along with UKLL 2014 maintenance. Again, he was given blinatumomab for MRD positive as well. So we were fortunate that blinatumomab was available by our patient access program. So we gave him 1 cycle of blinatumomab. He continues to be on ponatinib. He is in deep molecular remission, and flow MRD shows CR. So a bit of literature about Gilbert's. So Gilbert syndrome is characterized by intermittent unconjugated hyperbilirubinemia without structural liver damage. It's not uncommon in Caucasians and neither in Asians. So nilotinib inhibits bilirubin metabolism by UGT1A1. So Gilbert syndrome has been associated with nilotinib-induced hyperbilirubinemia. Increases in bilirubin also reported in patients with Gilbert syndrome treated with imatinib or dasatinib as well. Okay, so increases in bilirubin have also been reported with GS, not only with nilotinib, with imatinib and with dasatinib as well. Even though homozygous patients show a high rate of hyperbilirubinemia, Gilbert does not affect response rate and outcomes in chronic myeloid leukemia patients. There's a very nice study showing meta-analysis. I will just share. So incidence of biochemical abnormalities across the frontline nilotinib trial as well as second-line trial. So you see in phase 2 and phase 3 trials, in this trial, there were total 321 patients, and bilirubin elevation total in all grades was with 72 patients, and grade 3 to 4 was 7 patients. Then in the next trial, 25, and grade 3 to 4 patients. So as you see in all frontline as well as second-line trials, there were patients, but it did not have any impact upon CML remission. So FDA has approved more than 60 TKIs, including ponatinib and sunitinib. Meta-analysis of studies found bosutinib, nilotinib, or ponatinib with a high risk of hepatotoxicity than that of imatinib, while nilotinib and dasatinib has the same risk profile. So although isolated indirect hyperbilirubinemia is a known adverse effect, but treatment discontinuation based on this indication alone is not warranted. So I would like to have the expert's opinion upon TKI-induced hyperbilirubinemia. What are your experience in your clinics? And another question from my side, would you plan desensitization for DSA in this scenario when he has haplomatched brother, but donor-specific antibodies were showing very high MFI? So
let's go to Mike
over
first.
to Andy.
Let's go to Mike first.
I'm going to throw the desensitization question out to the group because I'll confess I'm the pre-transplant phase physician, and I'm not sure what I could say about that. But I think you raised a very elegant point about the TKI toxicities, how they change if you're using it in combination with induction chemotherapy. And I think we all have hesitation with liver enzyme dysfunction when you're giving anthracyclines, methotrexate, other things in the acute setting. Whereas in the chronic CML patient, there's a lot more tolerance for low to moderate adverse events that may just be biochemical. I think we see a number of things. The hyperbilirubinemia from the Gilbert's phenotype. We see lipase elevation, which my GI colleagues remind me is hyperlipasemia, not pancreatitis necessarily, especially if you investigate. So I think you really educated us on that, and it is probably again quite different in the chronic phase patient versus the blastic phase or the transplant patient population. Someone asked why imatinib wasn't started in combination, and I think that's revealing the fact that imatinib, was part of a lot of combination chemotherapy protocols, and dasatinib and ponatinib probably were favored in lymphoid protocols. This was an MPAL, if I'm not mistaken. So, a regimen with myeloid activity, I think there's a little less data. So I think, and there's the match point, study from the UK, which is ponatinib and FLAG-IDA chemotherapy. That's our my institution standard for myeloid blast phase disease. But I'm going to stop there because I think there might be some other comments from experienced audience members on transplant and the desensitization.
Dr. Grondetti, we haven't heard from you yet.
Yes. Hello. Yeah, I think what we have seen recently with the nilotinib-induced cerebrovascular accidents, we have seen at least 5 in the couple of months. So the prolonged use of nilotinib, sometimes it causes a cerebrovascular accident also, in spite of cardiovascular events also. So for that, I think we need a typical plan. I think as you have mentioned, minimum test we have to do at the time of every 3rd month, at least lipid profile. I think our diabetic profile, as you mentioned, I think otherwise it's very difficult. I think now it's very difficult to continue the same medication now. So CVA also is one of the complications of nilotinib. We have seen many such cases now.
Anybody
So I
else?
think
Mehreen, how high was the donor-specific antibodies?
so. They were more than 12,000, and they were against many antigens, not one. So we just left the haplotransplant as a bad idea because desensitization is quite an expensive procedure itself with the plaques and with rituximab and IVIG. So unfortunately, we couldn't do for this patient, and
Sure. So
he's
the risk of
good.
graft failure is high.
Yeah. This risk of blood failure is very high. So we don't opt for high DSI haplodonor transplant unless we think about desensitization. And yesterday evening, I was going through a very nice paper. There's a statistical difference in the haplo success after desensitization.
I didn't get your point. Is the patient now in undetectable BCR-ABL?
Yeah. Patient is fortunately undetectable BCR-ABL maintenance, and the patient is
Do you
fine.
have the access to blinatumomab to the extent, because the recent data have suggested that if you do by NGS, the MRD detection by NGS, that is even better. And even if they are negative by NGS, if you give blinatumomab 1 or 2 cycles beyond negativity, and then continue on maintenance for nobody knows how long for the TKI, that would be a good choice.
In this patient, we could get just 1 cycle, and that was also patient access program. So blinatumomab is not easy to get. There was an access program in which a certain age group patient have it, but in this case, we didn't try it again because he was having MRD.
Mike, what's your opinion on the extent of blinatumomab use if the patient is not for transplant? How much do you
at least two courses should be given, and then followed by transplant. So whenever we give blinatumomab, our aim is to get the patient into a molecular remission, followed by rescue stem cells. But in this case, we didn't have the option of transplant, and he's fortunate to have continued molecular remission.
Mike and then Hemant, perhaps?
Yeah, I have a question to Professor Mehreen Ali. Madam, why did we choose nilotinib in the first line? I would have thought that the best choice would have been either dasatinib or ponatinib.
Yeah, so very rightly pointed out, this patient was on presentation lymphoid and myeloid both transformation, that is MPAL, mixed phenotypic acute leukemia, and dasatinib was not very easily available at that point in time. So we started him on nilotinib, and then shifted to dasatinib in a hope that he would not have hyperbilirubinemia with dasatinib, but he continued to have indirect hyperbilirubinemia. So it was very unusual for us, and we searched the literature. Dr. Mariam Khan would be around. She searched lots of literature. And then if the patient is not having any symptom, it was the recommendation to continue with whatever we are doing. So UKL 2014 was continued after induction, CNS intensification, and all 4 cycles of consolidation followed by maintenance.
I wonder if your consultants, Dr. Mariam Khan and Dr. Hamad Javad, do you have any particular questions you'd like to bring to the floor?
Yeah.
Thank you very much, Madam. I think we have heard a wonderful talk on these 2 complicated cases. I was mostly concerned with the first one. So I think the issues to be discussed, they were discussed in details. Our point was the current situation of the patient, now that she's in last phase, what could we do about her? So, I think we have thought of one of the options of using HMA venetoclax or maybe going for some more intensive treatment. But as Madam has already mentioned, that the patient, after her long fight with the disease, she is currently not really willing for any further treatments. And as far as the second patient is concerned, unfortunately, I'm not very aware of that patient. But for the first one, I would say that the question in my mind is how well can we anticipate the long-term complications of patients who are taking TKIs, who are doing otherwise well. How can we prevent complications like thrombosis, like metabolic complications that we see with nilotinib? So that remains a sore point for us. Thank you very much.
Thank you very much, Hamad. You were discussing in the morning that this patient can be convinced for HMA venetoclax because she was not ready to get any extensive chemotherapy. She was not ready for FLAG-IDA. She was not ready for anything. So that is a question from the house, especially we don't have flow reports still with us, but that is a question.
Mike, would you like to round this up?
Yeah, I think the what to do next in the first case is very difficult. I think because her last 2 treatments were included asciminib and ponatinib, and I think your thoughts on other myeloid active regimens that may be less dangerous overall, it makes sense. Back to the question about how to prevent, and I think I don't know how it is in all of our corners of the world, but many CML patients are hard to come for follow-up and for adherence to this TKI therapy. And then on top of that, if we need to have them into primary physicians or generalists or internists, or even cardiovascular specialists if they're on nilotinib or ponatinib, ideally. But I think we have to try to keep shepherding patients to have good general medical follow-up, because you may pick up on subtle things. And I think the best we can do is probably just, again, proper cardiovascular health maintenance. I don't know if we have an answer to that question on how to prevent thrombotic complications. I think we just need to be aware, more aware of them, but that doesn't change things much. But I do still in my own backyard have patients who don't get into their primary care or generalists. They want to, they want to just focus on their leukemia.
So a nice way to round that up. And unfortunately, we have run out of time for the realities of long-term CML treatment, I'm afraid. Please bring questions at the end. We might have a short session there as well. But thank you very much, Professor Mehreen Ali Khan and Professor Mike Mauro, for your incredible insight and wisdom. Thank you, Dr. Javed, for coming to talk as well. Audience, for your contribution. I have never seen so many questions. I'm completely overwhelmed. Thank you, Mike, for staying on top of the chat there. There were so many and all similar. if you have outstanding questions that you'd like an answer to, you didn't get one, I will try and get you one afterwards. And with all the discussion there about mutations and mutation testing and so on, for those matters, please come to our next meeting, which is scheduled for 1 month's time, which is from the laboratory, where the capacity for setting up laboratories for BCR-ABL testing and also for mutation testing will be absolutely central to that discussion. So please come and get involved in that discussion then.